Welcome, everyone. Looks like we're starting to fill up in here. We'll give it just another half a minute or so before we get started. My name is Andrew Smith, and I am the Senior Community Engagement Manager here at the Depression and Bipolar Support Alliance. I am joined by Barb Johnston of MHA New Jersey, as well as Denise Babin of MHA Passaic County. And we're here to talk about the opportunity of 988. We want to share with you a little bit of information about 988 if you are not familiar or have not heard of it yet. And then we also want to talk a little bit about the advocacy opportunities around the new 988 number, as well as making changes to community crisis systems. So Barb and Denise will share some of that with us, what they've done in New Jersey. And then we're going to have a discussion about taking their example. What kind of local advocacy can you engage in as an advocate? And so with that, we just wanted to give a little bit of background about what is 988. 988 is a new emergency number that you can dial for mental health emergencies that historically people have dialed 911 for every type of emergency, including mental health emergencies. And the federal government decided that that was not appropriate and that we need a new number that people can dial in order to be connected with mental health services. And they decided that number would be 988, a 3-digit number that's easy to remember. It replaces now the existing 10-digit suicide prevention hotline. As well, it also serves as a place that people can call for non-suicidal mental health crises as well. And so even though the federal government decided that this should be a thing and has allocated funding for it, 988, like 911, is going to be at the local level. Cities, county, some state activity in order to make sure that when you pick up the phone and you dial 988, that there are appropriate services available. And so with that, I'm going to hand the microphone over to Barb.
Hi, everyone. Thank you for welcoming us to talk about something that we're quite passionate about in New Jersey. And as Andrew so well put it, 988 is just a very exciting and new concept for people who are needing support and access to behavioral health care. If you notice the title of this, it's called 988 and Community Crisis Systems. And what Denise and I will be talking about today is that it's not just 988. 988 is just the very beginning. 988 is the entry point for crisis community care, a system that is built in some states and is being built in others. And it is a best practice and evidence-based practice to have a continuum of community crisis care. Next slide. So a good way to think about this system of care is that you always want to have someone to call, someone to respond, and someplace to go. So 988, as Andrew said, was enacted as a national number across the country that every state is required to implement as they see fit. And it replaces other lines. And instead of people calling 911 for a behavioral health crisis, they will call 988. Now, things that they shouldn't call 988 for are domestic violence, where there are safety concerns or dangerous concerns. Those probably, or medical kinds of situations, overdoses, those would go to 911. But 988 really is, in New Jersey, seen as no wrong door for behavioral health crises. And behavioral health, for those of you just to see what this means, it really is any mental health crisis, any substance use crisis, any suicide crisis, anything under those categories for really adults, children, all populations. So we are seeing this in New Jersey as no wrong door. Someone to respond, go back if you would, thank you. So someone to respond would be, so 988 will assure that the individual is safe. Sometimes they will warm transfer that person to another resource. Sometimes they further support is needed. And this is where mobile crisis teams come into play. And these teams are a best, again, an evidence-based practice. There are pilots, successful pilots all over the country, where these teams are comprised of a behavioral health professional and a person with lived experience, a peer, who goes out and they do several things, the mobile crisis teams. So they will de-escalate, they will work with individuals to assure access to care. And most importantly, the opportunity is for engagement. So they can go back, and we all know that in order to really assure good transitions and planning and get people connected to services, engagement is necessary. So peers play a huge role here. I'm going to talk a little bit about our legislation, and our legislation in New Jersey requires the behavioral health crisis line to be implemented, and it also requires the implementation of community-based mobile crisis teams. And then the third area really is somewhere to go. So if a mobile crisis team is unable to resolve the situation and assure safety and continuity of care, then we have other resources, and other states have this as well. So we are building community-based crisis stabilization centers in the community. All of this is voluntary, and they will have medical support as well. We have extended our crisis early intervention support services. And then, of course, we have other kinds of backup through a hospital system, but that's only when that is really necessary. So we really believe that most crises can be resolved in the community. In New Jersey, I'm just going to give you a statistic that we do have what we call psych emergency services, and they are hospital-based, but 60% of the people who go into those services are discharged back into the community within a day or two without being hospitalized. So we believe a large number of those individuals can really get connected to services in the community with engagement and can avoid the trauma of a police interaction, avoid the trauma of being brought into a busy ER, and really can gain the support. And that is the model. That is an evidence-based model. It is a SAMHSA toolkit model. And this is where we're going as a country, we hope, to be able to handle crises in the community. Next slide. So we worked on a model legislation that is nationwide. We work closely with Lifeline, and then of course we looked at that and looked at also the federal law, as Andrew said, was passed. The federal law allows for 988 to be implemented, and it also allows for telecom to implement user fees. Now, that's how 911 is paid for. That is up to each state. New Jersey did not take advantage of that, and we'll talk a little bit more about that. But our state was one of the many, actually, that received a planning grant for 988. And we had a very large multidisciplinary work group that worked on the implementation. And of course, this and the whole crisis system incorporates the principles of Samhsa Mobile Crisis Response Plan. Next slide. So I should mention that this bill was signed into law in July of this year, and I'm going to tell you how we did it. As I mentioned, the services are coordinated and will be coordinated. That's outlined. 988 is no wrong door. And right now, as part of the implementation, there's a lot of background work going on in connections with 911, warm transfers for children's services, and really the key point of the legislation is that there is 24/7 response for de-escalation, assessment, stabilization, and very importantly, engagement in services. Next slide. So how did we do this? Well, it took a year and a half to really move the legislation through. We had a lot of iterations, and we did have a lot of interaction with all kinds of groups, all kinds of advocacy groups, policymakers, working with the administration, working with children's groups, working with the IDD populations, working with elderly, working with our substance use colleagues. So we really tried to do a lot of reach out. A lot of this came from, we have a mental health coalition. That is the 11 statewide mental health organizations in New Jersey. And every organization was extremely invested in moving this forward and really assuring good understanding of the value of community crisis work. So it isn't only now you could just remember 3 digits, it goes a lot further. It's really helping to educate everybody on the importance of being able to resolve crises in the community. So we discussed the bill content. We told everybody about the evidence-based models of community care that exist in many other states. And we also will be talking about sustainability. So as I had mentioned earlier, we did not include user fees. There are 4 states right now that have implemented user fees. And when we say a user fee, it's a very, very small amount of money. We're talking in general about $3 a year on a cell phone. And that would pay for this system of care. So legislators were very gun shy. It became somewhat partisan, and people were seeing it as a tax. But I think when you really think about how much this does cost, it really cost an individual $3 a year, which is just a very small investment for the amount of people that will use it. And we do believe that after a year or so of experience, we will have people who are much more willing to support a user fee on telecom. It is hopefully something that we're working on in terms of a plan and future legislation. And we are seeing bipartisan openness to this because, as you all know, I don't have to tell anybody on the phone that mental health is a nonpartisan issue. So that's the advocacy we're doing. The way that we worked this was that we had a presence at every single step of the process. If the bill went to committee, we were there testifying. We sent emails every time there was movement on the bill to every legislator. We had live written in testimony, and we certainly had voices of persons with lived experience. We're going to talk a little bit more about that in a minute. we really left, I would say, no stone unturned in terms of assuring that every legislator knew about this, and they do. So this law was passed unanimously by both houses, both the Assembly and the Senate. Every single person voted positively for this law. That rarely happens. So we chalk it up to education, and advocacy is education. And I would just encourage everyone who's listening to assure that people really understand the value at every single step. We also have a group besides the Mental Health Coalition. We also have a group which is called the Community Public Policy Group. Denise has been a member of this group for 15 years, one of our founding members, and has made huge contributions along the way. We asked individuals for their testimony. Some people chose to submit written testimony, and this was highly impactful. So Denise is going to share her testimony and talk a little bit about her experiences with the Community Public Policy Committee. But I just also want to say that legislators listen to this. And even if, you know, there's a lot of stigma attached to testifying and public disclosure, and people may be a little shy to do that at some point. Written testimony is also excellent to include, and it can be done anonymously. So I would strongly encourage all to do that. But at this point, I'm going to turn it over to Denise, who's going to tell us how her testimony went and a little bit more about the committee.
Okay, good afternoon, everybody. I'm Denise. I'm a peer. I've been working with affiliate with Barb for 26 years now. I started as a peer, and now I'm Director of Outreach Services. And I've been working with Barb for a very, very long with this committee. The committee is a wonderful way to advocate, because sometimes people have anxiety to do things on their own. So being part of a committee is a wonderful idea of getting ideas and bouncing off ideas of other members. And together as a group, unanimously go in and work on something. And I think that's very important, that you realize that you don't have to go it alone. Like if you're thinking about advocating with Andrew, there's Eric here that are sitting on today. They head up the policy, and they're always available to talk about the policies. However, our committee is made up of peers throughout New Jersey. So I'm up in northern New Jersey. We have people from South New Jersey, East, West, all over New Jersey. And it's just an amazing thing to be part of. I've been doing this for very, very long. And I believe it's also good when you go into advocacy or want to start advocating for something, that you maybe find a point person or a mentor that can teach you how to advocate properly, and to which systems you need to go and advocate for when you're advocating for different things. But 988, I'm going to read you my testimony in a minute. I think it's very important that this was implemented in New Jersey, and it's going to be very important for the nationally for this number to be implemented. So I'm going to read off some of my testimony. It was a written testimony. We were asking, about 10 people gave testimony from our group, and there were also other people that gave, physical testimony to the Senate and the Assembly. So here goes my testimony. I wrote, I am in favor of the new crisis line that is being established. I have experienced firsthand when I had to call the crisis team. I was traumatized, and my son, who was 10 years old at the time, was also traumatized. When a matter of minutes after calling the crisis team, 10 officers came banging on my door, as if I had committed a crime. They entered my home, separating my son from me. My son screamed and called out for me. All I wanted to do was talk. In the end of that horrible intervention, I didn't need to be admitted to the hospital. I believe if a peer specialist was available, I wouldn't have been traumatized, because I would have had the correct intervention. And I think it's very important that this number goes nationally, because there are so many people that can relate to my testimony and how they were mistreated when they called 911 to get mental health crisis. So thank you all for listening. If you have any questions, Andrew or Eric will read off the chat, and hopefully we get some questions here today.
Yes, thank you for sharing that with us, Denise, and thank you, Barb, for the background. And thank you, Eric, for encouraging people to put their questions into the chat via the chat. I apologize for neglecting that in my opening remarks. If you do have any questions, please feel free to add those to the chat. You can also raise your hand and we can unmute you. And you can ask your question directly. I did see a few questions that were more general, not specific to MHA New Jersey, that Eric was able to answer in the chat as we were going along. Eric, do we have any questions off the bat?
We did not. Well, I would be curious to ask Barb and Denise, what was your experience in talking to legislators? What were the, I mean, of course, exciting that was down as well, but what were the sort of resistance points, I guess, that you saw or you heard about? What kinds of things? I mean, obviously paying for this is one, but were there others?
Say there were two resistance points. One was around the user fees, which we really, are not giving up on, because sustainability is critical to keeping this crisis system in place in years forward. So that was one point of resistance, and that was from legislators for the most part. They just didn't want to impose any kind of fee on their constituents, and we're still working on that. The other point of resistance, quite frankly, was from the hospitals. Because hospitals wanted to continue to bring people in and assess them. And really, we believe that mobile is a much better way to go to avoid the trauma of ERs and to avoid, we do think that there's a place for hospitals, certainly. And when people, are having issues that requires hospitalization around dangerousness and other things, then they certainly have a place. But we do support community intervention wherever possible. And so, hospitals weren't terribly pleased with this. Now, we do have some ERs that are community-based, and they function very, very well, not attached to a hospital. So case in point, we really need to rethink and take some of the medicalization out of it unless it's really needed. We believe that a lot of it, and we have the stabilization centers that are being planned and built to support that as well when it is needed. But again, all in the community. And we believe that peers play a huge role with engagement and really, helping people have a comfort level of seeking services in the community when they're available.
I was just gonna, my next question was gonna be around the peers. I will say we've been pleased that the recommended strategies that are coming out of both SAMHSA and the National Council have included peers as part of this process. Can you say a bit more about how peers were included in the legislation? How did that get added in?
Well, actually, the law says that the mobile crisis teams will be comprised of behavioral health professionals and people with lived experience. Oh, so it's actually in the legislation.
Actually, in the legislation. That's great.
Yeah. Mm-hmm. And we're always, Denise and I are always advocating for lots of things for peers, including better salaries, more hierarchy, faster certification turnaround, all kinds of things we advocate for on a very, very regular basis.
Yeah, and me as a peer, I'm very fortunate to work with an agency affiliate of the MHA who uses a lot of peers. We've had at one point 11 peers working in the peer programs for us. So that's unheard of sometimes, that you have that many peers working with you in an agency. So I had good mentors. The executive director that I just took me under her wings. And at first I was really scared to testify anywhere. And she kept on sending me out. And she said, come on, you got to do this. And I learned that you have to have all your ducks in a row. So that means you have to have all the facts. And if you have a good mentor, it's easy. So Barb, when she gives us the facts, we can use these facts in written testimonies or when we go anywhere in physical to testify.
Great. In New Jersey, are the call centers, I can't remember how many call centers you actually have in New Jersey. They're usually regionally based in most states. I assume they've been part of this process, and but can you say a little bit more about the call centers in New Jersey and their how they play into it?
Yeah, there is one, I think, primary, and then there is 4 others that are connected to that primary. And they coordinate with each other on how calls are answered.
Okay, great. Well, for those there's a national contract from SAMHSA, goes to a group called Vibrant, and Vibrant then contracts with these local agencies, some of which are county-based, some are nonprofit, some are state-run. There's a variety of different ways they're run, but the system was in place, but with federal funding is being expanded.
Right. Through Lifeline. Yes.
Yeah, called Lifeline. Yeah, so that was already in place, actually, though. That was
right.
Yeah.
And they've been really helpful. They've been terrific. They are, if you need help in your state of moving something through, they will help you with advocacy. They're very, very responsive. I can't say enough good things about Vibrant and Lifeline and the support that we got from them throughout this entire process, as well as our national organization and your national organization, all of which are very cohesive in working together in Washington to move this forward. And then, really pulling it together so that everyone sees what the states are doing, it's very exciting. And we don't always agree with each other, which is very interesting. But legislators have said to me, on this issue, everyone is saying the same thing. So we're all speaking cohesively and in agreement about how important it is to build a community crisis system.
Well, thank you, Barb and Denise, for sharing with us and for joining us and answering our questions. I know that both of you have another obligation that you have to now leave our call, but we really appreciate you joining us and sharing with us. Thank you, thank you, thank you.
Our pleasure. Thanks. Bye.
Bye.
And with that, I will take over with the question of on the national looking at more broadly at other states in addition to New Jersey, a little more background about what is being done and what you can do as advocates to make sure that that this torch is being carried, that you can do similar work to what Barb and Denise have done in New Jersey and are continuing to do. I did want to provide you with a couple of statistics. So even though 988 went into effect on July 16th of this year, so we've had 988 for about 4 months now, 77% of people haven't heard about 988. So our approach to it at DBSA is kind of a 2-pronged approach. One is just to raise general awareness. Hey folks, 988 exists and you should use it. And so that is a communications campaign. That is also the work that we are doing in the department formerly known as Advocacy, now called Peer and Policy Advancement, So that's one piece of what we're doing on this call, is just to let the 35 of you know, hey, 988 exists. That's a new number that you can use. But like we said, there's also so much advocacy to be done around changing what 988 brings with it. As Barb and Denise both shared, it's so much more than just a new 3-digit number that you can call, that we can actually change what happens when you call that number. I want to refer back to some language that Barb used of no wrong door. What that means is when you call, they will point you in the right direction, that they will make sure there will not be a situation where you call and explain your situation and they say, oh, you need a different department within mental health services, call this number instead. That they will actually make sure that you get connected. And to Barb's point about which calls are still appropriate for 911 rather than 988, that in many states, they will be connecting calls that are misdirected. So when somebody calls 988 and they actually in reality have an emergency that requires 911, that they can be connected directly to 911 on that phone call. And there are differing opinions about whether that's a good thing or a bad thing. Some people think there should be a separation, that there should not be any connection to the old form of emergency response. But that's going to happen on a state-by-state basis. The next thing that I wanted to point out on this screen is that 86% of people believe that when someone is in a mental health or suicide crisis, they should receive mental health response, not a police response. Many of the people that are in our circles that wind up on Zoom calls like this one believe that. I have been at conferences about what is the promise of 988, what does it bring, what changes can we make to the system? And I can tell you that there are states where police will always be involved. And that has to do with the politics in those particular locations. But that what the advocates in those communities are pushing for is better mental health training, and for social workers, or in the what DBSA believes, peer specialists. That's an individual with lived experience of a mood disorder or other mental health condition or substance use disorder, who's trained on how to use that experience to help others process a mental health crisis that they're going through. We believe that they should be on these teams, that they should be taking a prominent role on these teams, not only answering the phones when people call, but those mobile crisis response teams that Barb mentioned, going out to meet with people, as well as the crisis stabilization centers, a place that people can go that's a non-clinical setting to process whatever it is that they're going through. Again, an excellent place not only for social workers and counselors, but also for the role of the peer specialist. And 89% of people agree that everyone, regardless of their location or income, deserves access to quality mental health crisis response care. So going back to what is the old system versus what is the new system? When you dial 911, there's really, well, first of all, you're not getting a crisis counselor on the phone. You are getting a dispatcher on the phone. Their job is to figure out what do you need and how to get it to you. So that person is not trained on how to de-escalate a mental health emergency over the phone. So that's the first major difference, is when you dial 988, you are getting somebody who is trained on how to de-escalate a mental health crisis over the phone. In many places across the country, that might be all that you would get at this point in time. But going back to what is the opportunity, we have with this new legislation and new funding and new opportunities for new legislations and new sources of funding to change where your services go from there. When you call 911, you get police, fire, or paramedics. And when you have a mental health emergency, even if you say, please do not send the police, please send the paramedics instead, most often the police are going to arrive on the scene. At that point, the police have 3 different choices of what they can do with an individual who's in crisis. They can take the person to jail, which is always a bad option if it's a mental health crisis. They can leave and just leave you as they found you, or they could take you to the hospital. Once you get to and we're talking just a regular hospital. We're talking the emergency department at the hospital where people are dealing with broken legs and all kinds of other trauma. And that's where you're supposed to go to process a mental health crisis. Once you arrive at the hospital, then you wait there for a mental health assessment. And at that point, then you are either admitted to a psychiatric hospital if the situation warrants, or you are released back to where you started. And those are the 2 options. And so what the crisis stabilization centers give us really are a non-clinical setting, a place that doesn't have all the chaos of an emergency department, that isn't as high of a level of treatment services as a psychiatric hospital, which is not appropriate for every mental health crisis. Some people don't need to be hospitalized, but yet being released onto the street is not the right option for them either. And so the Community Crisis Stabilization Center really gives a middle ground that hasn't existed prior to that. And then also connections to follow-up services as well post-crisis. And so I wanted to talk a little bit about, after hearing what Barb and Denise shared about MHA New Jersey and their advocacy efforts, a little bit around what we're doing to help you as our DBSA advocates to get involved. As I mentioned before, the federal government decreed that 988 should become a thing. And states across the country are working on funding and legislation to flesh that out. But really, it's going to be county or, as Eric mentioned, regional infrastructure is where these call centers, where these crisis stabilization centers and mobile crisis response teams are going to be housed. And that's where people on the ground like yourself are really the best people to carry that torch, get involved, and make sure that that we are building the system that is the best system that it can be. This is a map from reimaginecrisis.org. And I do have a disclaimer that this is not reflective of all of the legislation that is out there across the country, but I wanted to give you an idea. Going back to what Barb said at the very beginning of her presentation about not only building the system, but making sure that it's sustainable. How is it being paid for? Is there going to be a fee associated with phone bills that is going to make sure that this system is paid for and will continue to operate and going forward into the future? And so here's the map. It's actually an interactive map on reimaginecrisis.org/map. Eric, if you would be willing to drop that into the chat, people are not able to click on what is on my screen here, but if you copy and paste that, it'll take you directly to that website. You can also write this down or take, if you'd like to take a screen grab and visit that website. Barb mentioned coalitions and working with other like-minded organizations in order to improve the mental health care system. And the Reimagine Crisis is one of those coalitions. It's actually spearheaded by NAMI, National Alliance on Mental Illness, and there are a lot of resources there. And we have taken some of those resources to share with you, our advocates. And so I will put into the chat at the end of my presentation where you can find our version of the Advocacy Toolkit. But some of the things that you'll be able to find there are talking points that will help you, as Barb mentioned, whether it's providing testimony or having legislative meetings. There's also samples of letters to the editor that you could write, and sample social media posts, including social media graphics that so that whether you're putting this on your Facebook, Instagram, whatever the case may be, that the toolkit is there, it's complete. You can choose the image, the graphic that you want to use, and there are sample posts. You can edit those, of course, and write, add your personal story. But it really helps to get that ball rolling. If you feel overwhelmed, if you feel like you don't even know where to begin, that's a good place to start. There's a lot of resources that can help you to begin to get involved. So we've talked a lot about what's happening at the state level, and we just wanted to touch a little bit on what the federal government is also doing in order to facilitate this, in order to make sure that this is a reality. And so Congress, as I said, already passed a bill, but they're considering new bills to shore that up. They're also considering funding for the fiscal year 2023, which is including $1.4 billion for the mental health block grant, with 10% set aside for mental health crisis services and 747 million for 988 programs. And this represents a more than $1 billion increase over the previous years. And on the regulatory side, SAMHSA has funded $282 million to help transition to 988 from the existing suicide prevention hotline, as well as $177 million to strengthen and expand existing Lifeline networks, and $105 million to, so that's broken down into $177 million to expand those networks and $105 million for local staff crisis call centers. And the FCC is working around issues of geolocation identity. So I did see a question in the chat, and I'm hoping that Eric will be able to have an answer for that, about what do you do if you have a cell phone and you have a different area code than where you actually live. What I will say about this, and this is being addressed on a state level, is there are some questions of how much ability do we want to have to be able to find somebody who calls 988. If someone is actively suicidal and won't tell the person on the other end of the phone where they are, would it be beneficial for us to have geolocation services to be able to track that cell phone and send the mobile crisis response team out to that person? There's a whole bunch of questions around privacy around that. That is still being debated, but that is something that is being considered as well. Another resource that can help you learn more about 988 is the SAMHSA website. And Eric, if you could place that in the chat as well, people won't be able to click on my slide, but if you go to https://www.samhsa.gov/find-help/988, then we'll be able, there's more information there about what 988 will look like. And now I'd like to feature one specific page on that website, samhsa.gov, and that's 988 jobs. That's a place where, as we mentioned before, that the opportunity, not only for social workers and counselors, but also for trained and in many cases credentialed peer specialists, people with lived experience who are trained on how to use that lived experience as a paraprofessional. As I said before, there's opportunities on the answering the phones, as well as in communities that have them, the mobile crisis response teams, as well as in the communities that have them at the community crisis stabilization centers. So I did see one person's hand go up, and I also did see that the chat has been active. I have not been monitoring the chat, but I would like to open it up if there are any questions. Eric, are there any questions in the chat for me to address?
No. No, let's go to nothing right at the moment. I don't recall. Like I said, there was a hand up, so let's go to that person.
If you could raise your hand again, it appears to have gone down.
There's Tom Paulson.
And you should be able to unmute yourself now, Tom. Oh, now you should be able to. I apologize.
Okay, sorry. I'm Lori. This is my husband's account. I couldn't get in any other way but Google. It's very overwhelming. I was active in political stuff. It's been years. And because of a mental health crisis during a campaign, I pulled out. But here we are 20 years later, and such an issue such as this comes up where I can take my expertise of, what it is with political, substance, what you have to do, and my bipolar background, lived. And I'm just blown away by what you guys have done so far. I mean, this just got pushed through in July, you said, for 988. I know it was coming. I'm from the Chicago area. Illinois, I see we're still half participating. That doesn't surprise me. So I'm trying to figure out who I would, engage with to get the ball rolling so that we can be like some of the other 3 states. Colorado was one of them that are totally in place with this. I mean, is it a dream world to think that it should be in place right now, or is this something that to be patient about?
Well, let me jump in and answer the question this way. It's been pointed out that the 911 systems took over 20 years to fully develop out. And so think of this as we're developing out something like 911.
Okay.
This is just the beginning point. Some places have more developed crisis response systems than other places. The call centers have been better funded in the past, so they're more up to speed. 2 years ago, the National Crisis Hotline was funded at $20 million by SAMHSA. Now it's funded to almost $200 million. That gives you a sense of the amount of money being put in the pipeline, but like any program, it takes a while for that money to get to the place where
going.
stuff is happening. So
Okay.
it's a work in progress, I think is the question. So you raise a great question. Yeah.
So my most simple question to come down to, I want to hit the, ground running. What would I do? What would it look like to go and get started and try to, cultivate what should be done, what you guys are doing, like in Jersey and stuff? How can we mirror what, your action has been?
Sure. Every state receives a statewide planning implementation grant, again, through SAMHSA and Vibrant. So I would suggest first contacting your state mental health authority, whatever, every state calls it something a little different, and drill down there and figure out who's doing the 988 implementation work in your state.
Okay.
And the other source is NAMI. The local chapters
Right.
have really been taking the lead. So I would talk to your local NAMI chapter or MHA chapter.
Okay.
Yeah.
All right.
Yeah.
Thank you very
and
much.
You're welcome. I did put into the chat a Google Doc. That is where you can find our version of the Advocacy Toolkit that has been developed by these coalitions that are working on 988 implementation at the state level. I would encourage you to join coalitions as you become aware of them. And another way that is so critical for advocates like yourself is to join local mental health boards. Sometimes those are at the county level. Sometimes individual towns will have a mental health board. That's where these decisions are being made. And you can go and you can provide testimony before these boards, but you can also become a member of these boards. They are required to have people with lived experience on the board, and they're always looking for someone with lived experience to join those boards. And so that would be a slightly larger step, but that would be a step that an individual could take as well.
That is huge. That is absolutely huge. 1 year ago today, we were dealing with a suicide and I just went ballistic, bipolar ballistic, I called it, and I called out the superintendent, because we had 2 in a row. And so I just wish I could have funneled that energy into what I need to do now, because I was on a roll and I had a lot of ears listening, but I didn't have the background like you guys have here, where this is how it is. It's not just Lori Paulson saying this, it's here's what it is. And so, yeah, to get on the boards. The only thing, I was with my doctor today, I'll just throw this out here, you guys. We have had no suicides. God bless, I'm saying. This time last year, there were 2. We have none at this time. And I just, I'm hoping it's some of the efforts that we put through last year, but this is just, this is phenomenal. We can use our illness to the greater good. That's, yeah.
Great, thank you. Tori posted in the chat box a question about, but prefaced it by saying that she's hearing that peers are warning people not to call 988 because of the potential for involuntary hospitalizations. And then, where is this? How do you avoid that? Again, and I've heard this, across the board. Whether you call 988 or 911, the response is going to depend on how it's presented to the operators. If a person is clearly expressing harm or danger, it is very likely that that 988 may send some sort of response that includes police response. Now, keep in mind that many police departments are trained in crisis response, but it is definitely inconsistent and not always good. We certainly know that there are problems there. So like I say, there's no easy answer to this. She says that her question is a response consistent across states, and or will it depend on where you're located? Definitely on where you're located. Some communities have done a better job than others in developing these responses, and it's frustrating. But again, because of the resources that have been put into the system, I'd say we're seeing massive increase in funding coming to the federal government. And then if we can get more states to do the telephone tax, or not telephone fee, the telephone fee, that also will increase the funding into the system, and we'll do this. But again, it's going to be a long-term process. Jonathan, you said you have a question. If you want to just unmute yourself, feel free to ask the question. Yeah.
Will do. Thank you. Hello, everybody. Appreciate everybody that's been on so far, what they presented. I did want to say one positive thing that I've encountered with the 988 line is it does identify Google Voice number in the correct area code. And that's something like you can't call 911, at least not in Illinois, through a Google Voice number. It will try and make you call from your, from a regular cell phone number, so to speak. So I think that's a huge positive. My question is just around, so national implementation, if I'm just wondering, what, if anything, legislators in Congress, right, the Senate are doing in states where either it hasn't been implemented, right, or things are not, moving along, as if, because this is connected to a bill, right? So I hate using the word, but like enforcement of that, has there been any talk around, what's going to be done to make sure that happens? So that's my question.
Yeah, I mean, enforcement isn't the right word to use. I mean, this is not a legal criminal type issue that's being addressed. I think there's huge interest and momentum both at the federal level and at most state government levels to address this concern. Again, it's going to vary a lot in terms of how different jurisdictions choose to approach it. But yeah, I think that's the best answer I can give right now.
And if I could jump in, I see parallels in your question to what we've experienced with mental health parity, that when the federal government says this shall be a thing, and then it's up to states to determine what will that look like. And that actually would be a case where the word enforcement would be appropriate, but enactment for this one, similarly, it's going to be on the states to determine what that will look like. As I mentioned, I've been at conferences where people have said, in my state, there will always be police involved. And this was the head of Health and Human Services in that state saying it politically is not feasible for us to send out only social workers and peer specialists. And so then the best they can hope for is make sure those police are trained on mental health crisis response, and to have additional members of that team, social workers and peer specialists going out as well. So this is really going to look different in many places. Also, rural communities are in many cases are only going to have the 988 number that you can call and resolve a crisis over the phone. They may not have a mobile crisis response team that can come out to you. But this is that opportunity for us to not be satisfied with the status quo and to always be pushing for new and better responses.
No, I appreciate that. Yeah, I think the concern in my mind was coming from, a space where I was looking at the list, that you guys just Andrew, you just gave the link to that in that doc, that shows like, okay, here's what's going on in each state. And so I'm just wondering, like, if there are states where literally nothing has been done yet,
No.
you know, where's the accountability around it? So that's
I am not aware of any state where people have reported that nothing's being done. Again, as Andrew's pointed out, states that are more rural are having more challenges with this, is because of distances. And also states that, yeah, that's probably why I should leave it at that. But
No,
no,
I appreciate
every
that.
state is certainly taking action on this. Partly, yeah, I mean, they just yeah. Now, I see Nicole has said there's some concerns about the way crisis response is happening with police in her areas and fear around that. Again, it's going to take it's going to take time to develop the types of responses. And I think it's important, as I mentioned earlier in the chat box, is that over 80% of people who call a crisis response line have their issue resolved, either just talking to someone on the phone who's trained in that helps them. Maybe they just need, maybe they get a referral to a DBSA support group meeting, that sort of thing. I'm aware that some of the crisis response call centers are developing programs whereby they have frequent callers, and some people call them on a regular basis. They're actually starting to make regular calls to those people in advance of anticipating the call, just to check in with them, maybe a once a week check-in, and that's been hugely successful in reducing emergency situations where the person's calling them with an emergency, but by having them be responded to. So those are the kinds of things that we're hearing about. Other places really beginning to work on developing peer respite centers. It's a place where someone can go for a period of time, which is a peer-based non-hospital setting. We certainly want to see more of those developed around the country. That sort of thing. And again, as I mentioned before, just really working on the police crisis response training programs that are coming through. I see a hand up there. You want to say some more?
Yep, Lori again. Just quick, I'm referencing the map that was brought out. That's how I found out Illinois were partial implementation.
Yeah.
But the majority across the line, it says no 988 legislation considered, excludes appropriation study bills, but it says it hasn't been considered, and that's like almost every state from what I'm understanding with this.
So that wouldn't necessarily mean that there is no 988 number that people can dial in that state. Is there any state bills around what will 988 look like? Will there be more than just a phone number that people can dial and talk to someone on the phone? How is that being paid for?
Well, it's just unclear because I mean, this is pretty point blank to me. No 988 legislation considered.
The legislation had to do with the development of crisis response centers and crisis response efforts, not the telephone centers. The telephone centers were already in place. Yeah, I mean, now again,
okay, that's a little confusing. Okay,
yeah,
so the centers is what they're still developing, but that number throughout our country is in place.
You can call 988 anywhere, and it will route you to a call response center. Again, depending on where you're calling from, what area code you're calling from, it may route you initially to, for instance, if I'm in DC, if I'm in Chicago and I call 988, it's going to route me to the DC center. But as soon as I say I'm in Chicago, they're going to say, oh, hold on a moment. They're then going to transfer my call to the Chicago call center.
Okay.
And then someone in Chicago will talk to me. And again, it will probably depend on my initial setting. If I call and say, I'm in Chicago, but I'm feeling, they may talk to me for a few minutes. It really depends on how well they're trained. Also, I will say one thing about 988 that's different than 911. 911 callers are trained to get you off the call as fast as
Soon as
possible.
possible.
988 people are trained just the opposite. Their goal is not to get you off the phone. Their goal is to talk to you. Some people spend 30 minutes on a 988 call talking to someone, and then, like I say, their issues are resolved. So it's that second part, somewhere to go, somewhere, someone to respond. That
Well-
the 988 legislation is, and maybe we should call it 988 legislation, but the legislation is really working on how do we develop those types of responses.
Well, I mean, that's the thing, though. It's an empty, I mean, it's like a skeleton crew. You've got the number going through, but where are you directing these people? If you don't have these centers established or developed or, in the process, what am I going to do if I'm taking the call and I need them to go to a center? I don't have one. I mean, that's what it looks like throughout the state. It's just hanging in the trenches. I mean, that's just the way I read it, or, I mean, it's great that we have a number, but where is that number going to lead us to? Specifically, I know we're still in transition, whatever, from July, but you got someone on the line, bam, I want to make sure you get them to the right. I mean, it's common sense. You want to get them to the right place, but who knows how that's going to be established? I mean, who oversees that within your state?
The state mental health authority working with the state health departments and other entities.
And NAMI, okay.
Well,
so NAMI is an organization like ours. NAMI
Right.
is a patient advocacy organization who is
Right.
sounding the alarm like we are, and that is what we are doing right here, is telling you as advocates, we all need to raise our collective voice and speak up and say there needs to be more, that we can't be satisfied with just getting that number. And so, yes, the number went into effect 4 months ago in Chicago. If somebody were to dial, they will probably have more resources available to them than somebody downstate Illinois.
Right.
It will be a longer period transition for us to see this across the United States.
Okay. Thank you very much, you guys. You're very knowledgeable. I really appreciate it.
Thank you to everyone for all of your questions and for the discussion. If there's no other questions, we'll give you all about 7 or 8 minutes back in your day. And thank you again. I hope you find that Advocacy Toolkit is useful. I'm also going to drop into the chat where you can sign up for our Advocacy Newsletter. And that's also where we send our newsletter monthly to educate people about advocacy issues. And we also send out action alerts, and those are, click here to email your whoever. That could be senator, representative, that could be at the state level, it could be on the regulatory side of things, talking to Health and Human Services or whoever the case may be. I don't think that's going to be a clickable link, but if you copy and paste that out of the chat into your web browser, you can sign up for our advocacy communications. And we hope that you enjoy the rest of the summit. And thank you again for joining us today.